Good afternoon. Thank you for joining us for today's webinar. My name is Nastasia Walsh. I'm a program manager at the National Association of Counties. I'm going to be moderating today's webinar. This webinar is part of Stepping Up, which is a national initiative to reduce the number of people with mental illnesses in jails. And Stepping Up is the result of a partnership between the National Association of Counties, the Council of State Governments Justice Center, and the American Psychiatric Association Foundation. And Stepping Up receives generous support from the U.S. Department of Justice, Bureau of Justice Assistance, and other private sponsors for these webinars. Before we begin, just a couple of technical details to ensure everyone can view the webinar. And also just to let you know, the webinar is being recorded. It'll be posted on the Stepping Up Toolkit website for future viewing. Give us about 24 hours or so. You will receive an email tomorrow with a link to the webinar recording as well, so you can view it there. Also, to the right of your screen, you'll notice there's a control panel, and in this panel, there's a questions box. You can use this box to type in questions or anytime send us a message if you're experiencing any technical difficulties. If you have content-related questions for the speakers, I'll ask those during the Q&A. If you have technical questions, we'll respond to you in that questions box to help you resolve the issue. If you want to have a better view of the presentation, you can click the small red arrow in the top left corner of your screen. And also, just so you know, the slides for today are available in the handout section on your screen. So if you want to quickly print those out to follow along, you can do that. We'll also be posting them on the Stepping Up website with the recording at stepuptogether.org. Since we've already had a number of Stepping Up webinars this year, the entire 6 questions series is now posted on the Stepping Up Toolkit website. You can go check those out. So I'm not going to spend a lot of time talking about what Stepping Up is. If you don't know about the initiative, definitely go back and check out some of those webinars and check out the website, or you can reach out to us at any time if you have any questions about the initiative. But I did want to give an update that we now have 399 counties across the country who have joined Stepping Up by passing a resolution or proclamation committing to reducing the number of people with mental illnesses in their jails. So we're really excited. We're almost at that 400 mark. Please go ahead and check out stepuptogether.org and click on what you can do, and you'll see a full list of all of the counties listed by state who have joined the initiative. If you know that your county has joined the initiative and you don't see your name listed there, please send us an email and we'll be sure to recognize your county up on that map. You can also download a copy of the Stepping Up resolution on that website and take that to your board of commissioners or supervisors so that they can formally join the initiative as well. So thank you to all of you who have joined the initiative, and thank you all for joining the webinar today. As you all know, since you signed up, on today's webinar, we're going to discuss evidence-based strategies for addressing the housing needs of people with mental illnesses who have been in contact with the justice system. We have a number of speakers who are going to be on here today, experts, subject matter experts, and practitioners, and so we're really excited to have them on the call. I'll introduce each of them as we go along, so I'm not going to talk about them now. So our first speaker is Dr. Richard Cho, and Dr. Cho is the director of the Behavioral Health Division at the Council of State Governments Justice Center. Before joining the Justice Center, he served as Deputy Director of the United States Interagency Council on Homelessness, which is the agency that leads the federal government's response to homelessness. And prior to his time on that council, he served as the Director of Innovations and Research at the Corporation for Supportive Housing. So Dr. Cho, I'm going to pass it over to you.
Great. Thanks, Nastasia. And I'm excited to be on this particular webinar as my bio indicates the issues of the relationship between homelessness, housing needs, and people's incarceration in jails among people with serious mental illnesses is a topic that I've worked on for many years, and so this webinar is near and dear to my heart. I want to just remind folks that Stepping Up is an effort to try to reduce the number of people with mental illnesses in jails by applying a new kind of approach that's on the one hand data-driven, but really is an all-community effort where all the relevant stakeholders are mobilized. And what we've been emphasizing through the webinar series that we've conducted over the last several months that Nastasia mentioned is the really importance of applying this 6 questions framework to be able to apply that data-driven approach and to bring about measurable reductions in the number of people with mental illnesses in jails. And what we mean by data-driven is to be able to bring both the solutions to scale and at a level of scale and urgency where we can actually bring about the reductions that we need to see fewer people with mental illnesses in jails tomorrow than there are today. On the next slide, we've talked over the last several webinars about the importance of tracking progress and really making your strategies aligned around 4 key outcome measures: reducing the number of people who are booked into jails that have mental illnesses, shortening the average length of stay that people with mental illnesses spend in jails, increasing the percentage of connections to care, and by that we mean not only mental health treatment, but also supportive services as well as housing for people with mental illnesses that are leaving or diverted from jails, and lastly, reducing rates of recidivism. One of the things that we've consistently heard from counties across the country is the importance of housing and the need for more housing solutions to be able to achieve those 4 outcome measures. And I think housing really plays a role in across all of these 4 key measures. I think one indication of the fact that this is a topic that the topic of housing is one that is in high demand is the fact that more, I think, registrants are registered for this webinar, 550, I believe, than have been for any of the other previous webinars. And so it just shows, I think, the hunger and demand for ideas and solutions. So we'll be talking a little bit about those ideas. I wanted to provide just a really quick framing here just around what we're seeing in terms of the dimensions of the housing needs among people who are involved in jails that have mental illnesses, and a little bit of how we might think of a framework for understanding housing needs. And then I'll really turn this over back to Nastasia to introduce the other panelists. So on the next slide, just want to give a little bit of a snapshot nationally of what we're seeing in terms of this crisis. The best available national data we have, which comes from both the U.S. Department of Housing and Urban Development and the Interagency Council on Homelessness, shows that nationally speaking, about 50,000 people every year enter homeless shelters after being released from correctional facilities. And that's just from data that's reported directly to HUD. And it typically doesn't include people who wind up homeless on the streets or experiencing other forms of housing instability. But of the people who enter into homeless shelters, that's the data that's reported to HUD, it's about 50,000 people a year entering homeless shelters almost directly after prison or jail, and that's a pretty significant number. In addition, other studies have shown that of the people who are admitted to jails, about 15% have a history of homelessness in the prior year. And so we know that there is a kind of national crisis where people are cycling essentially from correctional facilities to homelessness and back again. On the next slide, I think this cycle between homelessness and incarceration plays out much more acutely in some instances where I think counties across the country through data matching, and you'll hear a little bit about that on this webinar, have identified a cohort of individuals where it's not a one-time experience where they leave jails, become homeless, or are homeless and then end up incarcerated, but really where they're experiencing a revolving door between homelessness and jails, and where 1 week they might spend in the county jail, the next week they might spend on the streets or in shelters. And this is actually a case study of an individual that was identified in New York City, and this graphic actually comes from the Corporation for Supportive Housing, who helped facilitate a data match between jails and homeless services to really identify this cohort of people who are bouncing back and forth. And here you can see over a 2-year period, a particular individual who basically spend their entire 2-year period bouncing back and forth between shelters and jails. Next slide. I think it's also important to understand how there's a potential kind of causal spiral here between housing instability and criminal justice involvement. So if you think about people who are currently experiencing homelessness, they are sometimes subject to a law enforcement response, whether it's in response to homelessness encampments or in the enforcement of policies that ban sleeping outside, sleeping in public places, or panhandling, where some of those policies and practices tend to quote unquote criminalize behaviors associated with homelessness. And so where homelessness in and of itself increases people's chances of encountering law enforcement and then also winding up in jail. Second, we know that the lack of stable housing often serves as a barrier for people to be considered for jail diversion. So York County, for example, may have an existing jail diversion program, or you have programs where courts might send people to services with supervision in lieu of incarceration. But in many instances, we've heard that when people are experiencing homelessness or have no stable housing to go to, judges and courts are reluctant to actually consider them for diversion because of their fear that sending them back out to the streets poses a public safety risk or a risk of not appearing in court. And so you see how stable housing actually prevents people from being considered for diversion and then end up spending more time in jails. Once incarcerated, the lack of actual stable housing upon exit or upon discharge tends to increase risk of recidivism. And there are a number of studies that have shown that people who have a lack of stable housing or who experience homelessness have a higher risk of recidivism than people who do have housing. And then finally, the fact that they have a criminal history can serve as a barrier to housing, where a number of housing options, whether it's private landlords or housing assistance programs, programs like Section 8 housing choice vouchers, can become less accessible because of a person's criminal histories, which then contributes to their greater housing instability as well as homelessness. And then you can see how this cycle continues again and again. When you look at the subset of people with serious mental illnesses on the next slide, when you think about housing needs, I think you also need to understand that for the most part, people with serious mental illnesses who have disabling conditions typically, in addition to needing a place to live, also may need help with paying for rent. They may be low income or on fixed income, such as SSI or SSDI, and therefore it's unlikely that they'll be able to afford rent on the private market. And we've seen in this country a growing gap between what wages and income can pay and where housing markets are driving rents to. Second, people with serious mental illnesses are likely also going to need assistance with maintaining that housing, not only finding housing on the private market or finding affordable housing, but also help with just managing their income and managing their money to pay rent, with housekeeping as well as activities of daily living, as not to mention treatment and other supportive services. So really, if you think about when we talk about housing needs, it's typically about a need for housing plus services. The next slide is an attempt to kind of really just illustrate that there's really a lot of different ways to coordinate housing with services. You'll hear in this webinar a lot about supportive housing and permanent supportive housing, which is an evidence-based model that has really, frankly, stacks and stacks of evidence that show that it not only is successful in helping people with serious mental illnesses to achieve housing stability, but also reduce their use of other emergency public services, including involvement in the criminal justice system. But what I really want to show is that if you think about housing plus services as a larger frame, you understand that supportive housing is one. It's frankly a very good way to combine housing with services for this population. But I think it stands as part of a larger continuum of options, including for people who have higher service needs, assertive community treatment teams that are paired with rental assistance. There's interventions like critical time intervention that are time-limited services, but that are coupled with rental assistance, as well as for people who don't need as intensive services, they may just need rental assistance linked to community-based mental health services. But really, for people with serious mental illnesses, you're talking about a need for high or more integrated supportive services coupled with their housing assistance. On the next slide, one of the things you'll hear about, and many of you who begin to engage your housing and homeless services counterparts to be able to address housing needs have begun to hear more about coordinated entry systems. And this is an attempt on the part of housing and homeless services agencies to try to better organize essentially the front door to accessing housing assistance. And so whereas previously access to housing and homeless assistance was a little bit of a difficult path to navigate. People would have to apply to many individual housing programs separately. Many communities have been implementing a kind of a centralized referral system for the array of different housing assistance programs in your community. And I think that I think is creating opportunities where it's easier to be able to figure out how to access housing for people who are jail involved. So So let me, and part of what's been driving, I think, according to entry systems, is the idea that the pairing people with the right housing level of housing assistance and the right level of services should be driven by an assessment of people's housing and services needs. That's a familiar concept to us. On the next slide, many of you are familiar with the behavioral health framework for addressing people's criminogenic and behavioral health needs. And essentially, this is a framework that the Council of State Governments Justice Center developed in conjunction with the Bureau of Justice Assistance to really understand how people, the interventions that we provide should be targeted and tailored based on an assessment of their criminogenic risk, as well as their substance use disorder and mental illness. And this framework essentially has led us to identify two different subgroups of individuals. People who have high criminogenic risk needs, so people who are at high risk of returning back to the criminal justice system, and who also have high to moderate substance use disorders or mental health needs. On the other hand, there's individuals with low criminogenic risk needs, but who have high mental health or higher moderate mental health and substance use disorders. And on the next slide, we've shown how these two subgroupings really, frankly, need different things. For subgrouping A, where there's a low risk of criminogenic behaviors, but they have significant behavioral health treatment needs, really the solution needs to be how we divert them from criminal justice, not necessarily with any intensive community supervision, but that we provide them with appropriate treatment supports. Really, subgrouping A is in one way the responsibility of the behavioral health system to better connect them to services. Subgrouping B, on the other hand, is the group where, in addition to behavioral health treatment and services, there needs to be a greater attendance to some of the factors that lead to criminogenic risk. And that's where some kind of new targeted approach that combines intensive supervision with treatment and supports is needed. So how might we combine this with a framework for understanding housing and service needs? On the next slide. On the one hand, in addition to assessing for criminogenic risk as well as behavioral health needs, we are also emphasizing the need to be able to assess more systematically for housing needs and risk. And that means going beyond asking people, do you have a place to live, but rather asking them the kind of questions that better understand what's their prior experience with housing, what's their ability to pay rent in the future, do they have existing support networks or family members that they can return to, or do they really need some form of targeted housing assistance. Through the National Reentry Resource Center, CSG Justice Center has actually developed a sample screening questionnaire that can be used to help better, more systematically assess housing and service needs. On the next slide, once that housing needs assessment is in place, you can imagine how you'd come up with different housing and services strategies for people who fit into subgrouping A and subgrouping B. Let's assume that within subgrouping A, there's individuals that have low housing needs, and there's individuals that have high housing needs. Same for subgrouping B. For individuals in subgrouping A that have low housing needs, really the focus should be on how you can help that individual find housing either at diversion or reentry, primarily focusing on helping them reconnect back with family or existing social supports. For those that have low criminogenic risk and high treatment needs, but also have high housing needs, in other words, perhaps they're homeless or previously homeless, that's where I think the focus needs to be on referring them to existing housing and services programs that are already available to people who are experiencing homelessness or who are in need of housing. I think what we need to focus on, and I think what this particular webinar is going to focus much more on, is the subset of individuals who are in subgrouping B, that is, they have high criminogenic risks as well as high treatment needs, but also where they have high housing needs, and where the focus really needs to be on a new kind of targeted intervention that couples housing assistance with supportive services, as well as with supervision and an attendance to criminogenic needs. And I think what you'll hear about today are some strategies that communities are pursuing to better prioritize and identify who is that subpopulation in subgrouping B, the individuals who really need a different kind of specialized targeted approach, and where I think that frankly should receive priority for our efforts in terms of addressing housing needs for this population. So with that, Nastasia, I'll turn this back to you to introduce the rest of the speakers.
Great, thank you so much, Richard. We have a lot of speakers on this webinar today, so I'm just going to jump right in, but wanted to remind folks that the the slides are available on the webinar software that you're looking at right now. You can grab them right from there if you want to take notes, and we'll also be posting them on the recordings. I know we're going through a lot today that's going to be really fast, so that stuff will be available for you afterwards. So now we're going to hear from Kim Keaton. Ms. Keaton is the Associate Director of Data and Analytics for the Corporation for Supportive Housing, CSH. And in this position, she works to drive and develop CSH's internal and external work using data to drive efficiency, efficacy, and impact. And she's going to talk about some evidence-based programs for housing. So Kim, the floor is yours.
Thank you, everybody. I'm really excited to talk about supportive housing for frequent users, the FUSE model, supportive housing with Stepping Up Counties today, and to have you hear after me directly from two really awesome communities that are planning to implement and have implemented the model. You'll hear it from the source about how this model really can work. I just wanted to say too that we've tried to note as we go along where some of the FUSE planning framework and tenets lines up with the 6 questions and the 4 measures of the Stepping Up initiative. Next slide. Great. So for those of you unfamiliar with CSH, we're a national nonprofit doing work in nearly every state to advance housing solutions that improve the lives of vulnerable people, maximize public resources, and build strong, healthy communities. Next slide. The SH in CSH obviously stands for supportive housing, and high-risk, high-need populations who are homeless. You know, as Richard says, supportive housing really is the solution. So a little bit about what supportive housing is. It is affordable housing, as Richard noted, where supportive service providers actively engage tenants in flexible, voluntary, and comprehensive services and work with property and housing management to support tenant stability and ensure that housing remains a positive community asset for the long term. Supportive housing is an innovative and proven solution to some of communities' toughest problems, and it really provides the scaffolding for delivery of more effective and responsible public services. So as you see here, the housing is affordable, permanent, and independent, and the support is flexible, voluntary, tenant-centered, and the services are coordinated. Next slide. These are examples of who supportive housing can help, but you know, these are not the only categories of people who could benefit from the model. In the housing world, we like to say that supportive housing is really best for people who, but for the rental subsidy or rental support, wouldn't be able to afford housing, so their income unstable, and but for the supportive services, wouldn't stay in housing. Supportive housing is best for vulnerable people, and like the individuals with SMI that tend to cycle in and out of jail and are the focus of Stepping Up initiative, this can really work for them. And I should note too that supportive housing and the FUSE model that I'm going to talk about can also include families and youth of transition age. So it's usually helpful to point out what supportive housing is not. It's not transitional housing, and it's not halfway housing. It's not long-term or residential rehabilitation, nor is it a higher level of care like nursing home care or long-term hospitalization. It really looks like where you and I live, usually an apartment with a lease. Next slide. So why supportive housing for Stepping Up Counties? Why are we bringing this to you? Well, first of all, it's evidence-based, and I know that's important for the interventions and the tools you're implementing in your communities. It both stabilizes individuals along with reducing system use, so it can really help reduce recidivism in your communities. As Richard noted, it's the key strategy for ending homelessness in the United States, and much of the funding that goes from HUD supports this model. It's really ideal for the most vulnerable in terms of, you know, the folks that you guys are looking to help, the high utilizers of jails, people with multiple mental, behavioral, and physical health challenges. for whom we can provide wraparound support services like an ACT model that help keep a person stable and housed. And this can really help increase the percentage of folks that are connected to care for people with SMI in jails. And finally, when it's used as a diversion strategy, either pre or post arrest, it can reduce the number of people being booked in jail who have SMI, which I know is a major goal of the Stepping Up initiative. Next slide. So FUSE, what is it? The acronym stands for Frequent User Systems Engagement. That includes both the consumer, the target group, and then the systems that must be wrapped around to help them. What it really is about is, it's targeted at, the folks that in every community have chronic health conditions that cycle in and out of jails, diversion courts, hospitals, and emergency rooms, and are homeless at great public expense and with really poor human outcomes. We really know that supportive housing for this most vulnerable and costly group can reduce costs while getting better outcomes for both people and the systems that serve them. By finding a solution to the frequent user issue and getting multiple stakeholders around the table, we believe and we've seen that the FUSE program can serve as a catalyst for systems change and can support resource realignment and meeting shared outcomes across systems. Next slide. So this is what we call our FUSE blueprint, which is really a planning framework for starting a FUSE initiative rather than a program model. We've helped many communities implement high utilizer initiatives. Now, if you could go to the next slide just very quickly and then go back, you can see here we've helped communities in various ways across the country with these types of initiatives, everything from urban counties to rural cities and counties. So at the core of FUSE are three essential pillars. First, data-driven problem solving. Data, particularly a data match, is used to identify a specific target population of high-cost, high-need individuals who are shared clients of multiple systems. Jails, homeless shelters, crisis health services are some examples. These individuals' persistent cycling indicates the failure of traditional programs, and this is a high-risk population. The second pillar involves policy and systems reform. So this is where a multi-sector working group across systems and stakeholders is engaged in a collective effort to address the needs of their shared clients and to shift resources away from those costly crisis services. And finally, of course, we have targeted housing and services. So supportive housing, which is permanent, affordable housing linked to individualized supportive services and enhanced with targeted and assertive recruitment through in-reach into jails, shelters, and hospitals and other settings, helps clients obtain housing stability and avoid returns to jails and other institutions. So 2 slides forward. Thank you. These are examples from 3 2-year evaluations of FUSE initiatives or initiatives that were modeled or informed on the FUSE program or FUSE planning framework. You're also going to hear about another community, and that's the evaluation from Harris County in the end. So I'll let Dr. Hitz talk about that. Most recently, from Charlotte, North Carolina, Mecklenburg County in September released the results from the 2-year evaluation of the MEC-FUSE initiative, where they found significantly fewer arrests, of course, a lot of fewer shelter days, and then additionally, 24% reduced ambulance charges and almost 50% reduced hospital charges, even though they weren't even targeting people who had high healthcare utilization. They were targeting those individuals who were homeless and had a high number of bookings at the jail. These results were similar to the evaluation of the New York City FUSE program, which was the first FUSE initiative in the country. In the middle, you have results from San Diego's Project 25, and you see how these sorts of utilization reductions can be translated into offset public costs and calculated across systems. And so you see that once the reductions in ambulance use, ER use, inpatient hospitalizations, arrests, jail days, in addition to reduced use of the homeless system, resulted in net savings calculated at about 2%, 200%, I should say, after paying for the housing and services. So a pretty dramatic reduction in utilization and corresponding cost offsets. Next slide, please. So now I'm going to go through 3 things to do to begin the process of developing a FEWS initiative locally. The first is to plan and launch a FEWS steering committee. So planning and launching a FEWS steering committee is not really unlike some of the work you've already done to get support for participation in the goals of stepping up already, so that county resolution, proclamation. It doesn't need to be as formal, and there may be some new players to think about. What you need is really the most important thing is a FEWS champion. A FEWS champion is the person who can, bring the proverbial person who can really bring folks to the table. I've seen this be a county commissioner, a social services agency lead or director, a sheriff or sheriff's deputy, or a homeless continuum of care lead. A FEWS champion can be useful in generally informing stakeholders about how your county is looking to do FEWS to permanently stop the cycle of homelessness and incarceration for people with mental illness in your community. You should also think about establishing a project manager for FEWS, and that will be someone who can report to the FEWS champion and who can lead the work through all the steps of the blueprint and has time to schedule those meetings and ensure things keep moving through the planning process. While there is a larger stakeholder group for FEWS planning, I just want you to remember that these individuals touch many systems. So in a sense, they are shared by all those systems. It's key to have a steering committee. So stakeholder large group, then smaller steering committee. This usually would include county social services, for example, COC leads, behavioral health system representatives, and key people from the justice system like a sheriff's assistant or deputy or person from the courts, and potentially a county manager or executive's office representative. In question 1 for Stepping Up's 6 questions that county leaders should ask, they recommend a clear vision and the inclusion of commitments such as MOUs. We also recommend this for FEWS steering committees. And they can be time limited to a 6-month planning process, for example. They don't need to go on forever. This helps to formalize the expectation that key stakeholders will be in attendance for planning meetings. Finally, FEWS steering committees should really plan to keep meeting after implementation. All right, next slide. Second thing you should do is really use data to find that target population. So really, data matching is really the best way to identify who exactly are the most frequent users of more than one system's costly services. You can use this data to utilize a list-based outreach or in-reach approach to ensure that you're really targeting the most vulnerable and costly, and that you're getting the folks that are missed by traditional approaches. As you go along, data can also be used, of course, to measure and track program implementation and to evaluate the results. Hopefully, eventually scale the model beyond a pilot. The next slide shows a simple example of a data match. So you saw what Richard showed you of one single individual person cycling through jails and homeless shelters in New York City. This shows you what the results of a data match might look, for example, on your desktop for folks that are really trying to find those people in the communities that you're serving. This is just corrections data and homeless system data matched against each other. I think everybody who was in each system in the past year, and then their past 5 years of bookings, charges, and release dates, and their past 5 years of shelter usage, along with any other indicators that might show psychiatric disorders, substance use, etc. You should note that, of course, you should have the proper data sharing agreements in place before doing anything like this. But what you see here is aggregated per individual, the number of jail bookings, the number of shelter stays, and you can use not only this type of list to figure out who's the most frequent user, but you can also use this type of list to figure out what the thresholds of targeting thresholds and eligibility thresholds you want to look at are. Next slide. So the third thing is going to sound, it's not as simple as this sounds, but scanning and creating opportunities for supportive housing For any FEWS initiative and any supportive housing work, it's important to understand the availability of housing and supportive housing to stabilize the identified target population. Connecting with the Homeless Continuum of Care, so of course that's the coalition of HUD-funded agencies that provide housing and services for a homeless population, is a good starting point to understand the current supply and availability of supportive housing. COC should have information on scattered units available in the community, usually called scattered sites, and are available typically from private landlords. In addition to single site supportive housing, which you're going to hear more about from our friends in Iowa, and also supportive housing that is integrated into mixed settings. Next slide. So a key element of FEWS is to look ahead when you're planning at the expected housing need that is usually determined by the data match, and begin to develop a pipeline of supportive housing. Developing supportive housing requires capital for building, subsidies for building the building, and subsidies for the rent, and sustainable funding for services. Some of the partners in the community for finding these funding sources will be for services, state and county mental health agencies, the HUD Continuum of Care or SAMHSA, and then potentially foundation grants, and in some circumstances, Medicaid can be used to pay for tenancy supports and case management. The Veterans Administration has also implemented funding through the HUD-VASH program, of course, for services and rent subsidies. For capital, you look to local landlords and existing properties, state housing finance agencies who administer home funds, low-income housing tax credits, and local housing trust funds. For rent subsidies, the primary source is usually the local public housing authority and the Continuum of Care, although some states have begun launching their own state rental subsidies, which is great news. For a lot more information on, creating supportive housing, please check out CSH's website and our training center. The next page just has my email and a couple of links, although we have a lot more resources on our website. So now I am done, and I'm going to turn it over to the next speaker.
Great, Kim. Thank you so much for that overview, and thank you, folks. Folks have been sending in some questions about your presentation, so we'll get to those at the end after we have our last two presenters. So now I'm going to turn it over to Chrissy Canganelli, who is the Executive Director of Shelter House, which is located in Johnson County, Iowa. She served as the Executive Director since 1998 and has led the organization through substantial growth and change in that time. Chrissy is also the chair of the Johnson County Local Homeless Coordinating Board and a founding and current board member of the Housing Trust Fund of Johnson County. She also serves on the Johnson County Affordable Housing Coalition and was appointed by the governor to the Iowa Council on Homelessness as the chair of the Policy and Planning Committee. So Chrissy, welcome, and the floor is yours.
All right, thank you, Nastasia. This afternoon, I'm just going to share information on a new intervention that we're moving forward with in 2018, which is a Housing First intervention, and then follow up with some information regarding a current permanent supportive housing program that we've had in place since 2011. So first of all, to speak a little bit about our FEWS Housing First initiative. Next slide, please. And to give a little bit of introduction on our community, Johnson County, Iowa is home to the University of Iowa. We sit astride at the intersection of two major interstates and house 3 hospitals, each with their own psychiatric inpatient unit. Simply the combination of the geographic location of our community and the psychiatric inpatient units, those two issues do draw more of a chronically homeless population to our community. So we have a higher confluence of individuals that are falling into the chronically homeless population. But over and above that, our community has the highest housing cost in the state of Iowa and the lowest vacancy rates at less than 1%. And this exacerbates the challenge of homelessness overall throughout Johnson County. So a healthy vacancy rate is typically noted at anything between 5 and 7%. In the 20 years that I've been working For Shelter House, we've never had a vacancy rate that has approached anything near that, and that in part has informed our intention to go with a single site for our Housing First program, and I'll speak to that in a little bit. Next slide, please. So Shelter House is a homeless service provider, and we've been providing emergency shelter since 1983, and throughout the years have developed a very substantial continuum of services all the way through permanent supportive housing. So we're relatively known, or we are a very known entity within our community, and we have deep partnerships throughout our community with both public and private partners. Several things occurred during, starting in 2013, that really paved the way for us to be able to change the local dialogue and to begin to talk about something that would otherwise have been received as quite a radical proposal for our community, quite frankly, and to begin really talking about housing first. So I'd like to share a little bit about that. In 2013, our city council passed an ordinance restricting panhandling in the downtown area, and that was as a result of there was substantial development going on in the downtown pedestrian mall area, which constricted pedestrian walkways. And the downtown pedestrian area is a space where folks that are chronically homeless and living on the streets are known to congregate and spend a great deal of their time. So the area that they could be in and exist in was very constrained for that entire summer, and that led to increased and more volatile interactions with individuals because they weren't able to disperse more generally than they had in the past. So people were drawing more attention to themselves, and it was negative attention. There were increased conflicts, and that recommendation for the ordinance was as a result of that kind of pressure cooker summer. Local homeless advocates at that time, we chose not to really come out in force opposing the ordinance. We were not supportive, but we stood back and kind of just held on to that moment, and it was intentional, and I'll get to that in a second. The second thing that happened that year was that it was the year of the quote-unquote polar vortex. For anyone listening, if you're part of the more northern states, you'll remember that winter. It was absolutely horrendous and bitter. And local leadership, including the Iowa City Police Department, came to the local homeless coordinating board and asked if we could together figure out a different shelter solution for folks that were chronically homeless. Because Shelter House, as an existing shelter, has requirements and sobriety expectations that are functional barriers for our chronically homeless. So it was because of that polar vortex and just overall a heightened awareness that people had about the numbers of people that were chronically homeless on our streets, that there was just this timing and this confluence of interest and opportunity to change our dialogue. So between these two events, local homeless services advocates, we began talking about housing first as a different intervention. Now, we may have had an entirely different intention because we want to see people housed. We want to end chronic homelessness in our community. We didn't have to have the exact same motivations as other leadership in the community, but we found this common ground. We all wanted to do something and change and help and move forward, and it was just the time was right to be able to talk about this more, if you will, radical approach, housing first. So we started educating ourselves, we started educating the broader community as to housing first as an overall intervention, and developed a cross-system steering group, kind of as Kim had mentioned, the foundation of our FUSE project. A cross-system steering group formed, and we identified individuals that would represent University of Iowa Hospitals and Clinics, the psychiatric unit, Iowa City Police Department, jail diversion, our mental health services providers, our treatment service providers, our housing authority, homeless service providers. We had individuals from each one of these entities that were participating on our steering group. And before we ever really were able to move forward with the FUSE project, if you will, something that I've kind of jumped over, but it informed our work and galvanized support all along the way, was in response to that winter of 2013-14. We created a low barrier shelter that was just seasonal and has run every winter since, targeted and intended for chronically homeless. And each winter now, just through that low barrier shelter service, we are sheltering anywhere from 150 to 175 individuals who would otherwise be sleeping on the street. They would not come into our existing shelter. They'd be out in encampments or in parking ramps. Now, each winter, they have a safe, warm place to sleep. The community as a whole, as a result of just that emergency shelter, has been able to see a decrease in vagrancy calls during the hours that were operational of anywhere from 67 to 74%. Calls for ambulance services are down. They're not seeing people in the emergency rooms. There have been no reports of frostbite, and no one has died on our streets due to exposure. And that, all as a result from that low barrier shelter, has helped to really pave the way and continue to galvanize support for our ongoing work to bring Housing First to our community and provide a permanent solution and intervention for folks that are experiencing chronic homelessness. Next slide, please. So this has been kind of talked about a little bit already, but who we're looking at addressing and working with is folks that are falling into that, not just the chronically homeless population, but the frequent users within the chronically homeless. So if you consider the entire homeless population as this pie chart, about 84% homelessness is a short-term, one-time event. And the current interventions and ways of being, most specifically with our move to rapid rehousing and rapid transition into housing, those interventions work really well for that 84 to 85% of the homeless population. 16% chronically homeless, and for our community, it's frankly a little higher. The current interventions don't work very well, and this is where permanent supportive housing is a substantial need and very efficacious. For our first move into Housing First, we are specifically looking at this very small sliver, which is about 3 to 4% of the overall homeless population. And it's those individuals, as Kim spoke to before, that are frequently cycling through the different interventions: hospitals, emergency rooms, psychiatric facilities, substance abuse services, our shelters, and jail, only to resolve with living back on the streets of our communities. Next slide, please. So this slide just readdresses kind of this cycle that people get caught up in. And if folks remember the story of $1 Million Murray, this is exactly who we're talking about here. The chart makes this, or the slide makes this look like it is kind of an organized circuit. It is not. Those arrows should be going every which possible way. It's quite a frenetic experience. And again, just to reinforce that people are cycling through all of these different services, different interventions and systems to only resolve with living and dying on our streets. They're chronically homeless. They have complex behavioral and social problems, often co-occurring diagnoses. The traditional ways of being, our traditional interventions, do not work, and their care is almost without exclusion crisis-driven. Next slide, please. So back to our cross-system steering committee, our FUSE steering committee. The first step that we identified would need to be taken is we needed to assess what our local costs were. And I'll just say that everyone who agreed to work on this committee and on this project starting back at the end of 2013, everyone was volunteering their time. So we did not have any additional funding or resources to do this project, with the exception of, we did get a planning grant from the Corporation for Supportive Housing. So I put a plug out there to you. We would not have been able to proceed. We had an award of $15,000 that did help with the project management along the way. But other than that, all other time was donated on the project. Our first step was to do an assessment of what the local costs actually were and to create kind of a baseline for which we'd be able to determine what the costs of the current service utilization were for frequent users in our community. up until that time, we really only had an anecdotal understanding of people's experience. So you'll see on the left-hand side of the slide, we were able to identify iterate charges, costs for the services indicated. And then to be sure that we were in the ballpark, we compared those costs to reports from the U.S. Interagency Council on Homelessness. And almost without exception, we were in very close proximity. There were some exceptions, such as detox is almost double, but we reinvestigated that, and those are accurate for us. And again, where we had multiple providers, we used averages for the costs. And this is all 2014 data, so it's probably maybe not substantially higher, but it is higher than it was then. So this formed our baseline. After we had a good idea of what the costs were across these different service interventions, we then needed to identify individuals in our community. Again, we had an anecdotal understanding. Our community is small enough where most of us know folks by name. We started with police data, however, and the police officer that served on the committee generated a list of individuals that had the highest police interaction and were also known to be chronically homeless. So from that list, we had about 26 names, and that was public record. So we could take that list of 26 names and circulate it around the steering committee, and people individually identified people that they would go back out, who they felt that they had a strong relationship with, and reached out to them to see if people would be willing to sign off on the necessary releases to participate in an in-depth case study in which we would be able to analyze and assess people's costs of service utilization. So from that list of 26 names, again, of individuals with the highest interactions with police and were chronically homeless, we had 4 individuals that agreed to work with us. Next slide, please. The list of the 4 individuals, there was entirely random as far as how people came to the top. It was only because they agreed to work with us. We did not go in and select individuals with an intention of being able to show an array of costs or of service utilization. So I think that that's important. So other than beginning of the 26 names and the fact that everybody on that list had high police interaction and were known to be chronically homeless, the selection of the 4 was random and just based on the fact that these were 4 people who agreed to work with us and signed the necessary releases. So we were able to, with those releases in hand, go back and over about a 4.5-year period, analyze and collect all the costs of services and the incidence of services for these 4 individuals. And what we found was a very substantial range, with the low, you'll see with Kent at just under $57,000 for Kent per year, and the high for Ted at just under $200,000 average cost per year for the research period. So the overall average for the 4 comes out to just under $140,000 of unreimbursed costs to our community per year, only for individuals to resolve with living back on the streets. And this is the information that has become the foundation for our educating policymakers and providers throughout our community as to the current costs of not doing anything differently in our community, and that there are indeed individuals that are living and experiencing this in our community today. So next slide, please. So we took the data and in every possible permutation and combination that you could imagine, kind of ripped it apart. And this was one permutation that we thought was very impactful because we had an intention of making a case for housing first, a permanent housing solution. When we looked at the 4 individuals that chose to work with us, over the research period, one of the 4 individuals was sheltered in the highest cost possible housing or shelter intervention that exists in our community. And for us, the takeaway was and is that we're already housing and sheltering individuals in the highest cost possible way that there is, what could possibly be the opposition to providing them a home? Next slide, please. In summary, over the course of the research period, total costs that were analyzed and collected, we had just under $2.16 million total costs, $1 million in total costs for these 4 individuals. And if anything, that estimate is low. The legal expenses, we were given a range by our county attorney as anything from $1,000 to $50,000 per legal event, and we used a multiplier of $1,000. So again, if anything, the estimate of $2.16 million is low. This money, over $500,000, is being incurred. These expenses are being incurred year in and year out just for 4 individuals, only for them to end up living on our streets. Next slide, please. In encampments that look just like this, this is a picture of an encampment underneath one of our bridges in downtown Iowa City. So $500,000 a year just for 4 people to live like this, but not just to live like this, to die like this. We've had 2 people out of that study experience that have passed away since our research has ended. And we know as a community that we can do better. Next slide, please. So we are making the case for Housing First, which is, and this is recapping Kim's presentation, but permanent supportive housing. Participants are offered a home first. It's cross-system collaboration and wraparound services. That's an essential component to this. But that service participation on the part of the tenant is voluntary. It is not a condition of tenancy. Next slide, please. If we're successful, we should be able to show a cost change of about 60%. That seems to be the overall average in programs that are being implemented in the pre versus post housing costs. And I just want to reinforce, as far as a cost change, we're not saying that our jails are going to shut down, that our emergency room is going to shut down. We understand that those costs continue, but that for these individuals, the individuals that we're able to house, we should be able to show and demonstrate a cost change in their service utilization of 60%. And it will almost immediately pay for the housing, both the construction and the services, within the first couple of years. Next slide, please. So these are the plans, or this is the rendering of the building that we intend to build. It's a 24 one-bedroom apartments, very efficiently sized, just over 330 square foot per apartment, 2-story building with case manager offices on site, clinic for behavioral and primary health services to come on site, and just a very streamlined, straightforward building. Next slide, please. To this end, in July of 2016, the City of Iowa City Council amended the zoning code and created a new housing type called long-term community housing. And in zoned areas, we face no legal opposition to the project because of this code change. In October of 2016, we purchased land that was zoned accordingly. So again, we face no legal opposition to this project. All architectural and engineering services on the building have been donated. And as of August of 2017, we secured all funds needed for the construction project. And primary funding for this has been National Housing Trust Fund dollars and local Housing Trust Fund dollars. And we hope to break ground in March of 2018. Next slide, please. And just a brief information on the current permanent supportive housing that we've had since 2011, which is our Fairweather Lodge program. Next slide, please. This is a scattered site housing model. It's permanent supportive housing, but it's communal. So we own 3 homes through which we provide permanent housing for people living in community. It's peer-driven, and peers within the group vote people up and down across 4 different tiers within the training period. Supported employment is a component because the premise is this model is for people who are experiencing serious persistent mental illness, and the premise is that people to maintain their health and commitment to a life of mental health recovery, that employment is fundamental to that. So this approach is not for everyone. Mental health treatment is a core component of the housing model as well, and we have a psychiatrist. We have dedicated hours each month in a partnership with the University of Iowa Hospitals and Clinics. But another kind of very unique part of this is that the individuals living in the houses, they're managing their own medication. So they take their medications together, they document it, and it is something that they hold themselves accountable to. Because of that, med compliance is typically at 99, if not 100%. Next slide, please. So the Fairweather Lodge is, in our community, prioritized for adults experiencing homelessness. They may or may not be chronically homeless. They have an Axis I diagnosis. They're willing and able to work, again, interested in a life of mental health recovery, currently abstaining from drugs or alcohol, and willing to live in a peer-supported environment because it is community living. Next slide, please. In our recent analysis of pre and post housing impacts for the program and for participants in the housing, these are the different indicators that we have found. So psychiatric stays have decreased by 90%, hospital stays have decreased by 79%, emergency room visits have decreased by 90%, inpatient treatment has decreased by 90%, and jail stays, the slide says 97%, but that was my typo. It's 99.7% decrease, and prison stays have decreased by 100%. The costs for the program are 82% less than the pre-housing costs. And these impacts, while very significant, cannot begin to convey the transformations that we've seen in people's lives, but given the topic today, I think it's very relevant. So with that, that is the end of my presentation. Thank you.
Great. Thank you so much, Christy. I appreciate it. Great to hear about the work happening in Johnson County and in Iowa. I'm going to go quickly over to Dr. Regina Hicks, who is currently the director of the Harris County, Texas Mental Health Jail Diversion Program, which is a 5-year pilot program funded by the Texas legislature. And Dr. Hicks is responsible for the development and implementation of a program designed to reduce recidivism and the frequency of arrests and incarcerations for people with mental illnesses in Harris County. So Dr. Hicks, the floor is yours.
Thank you very much. Very happy to be part of the panel. Next slide. This is just gives you a little bit of information about Harris County. Harris County is the largest city in Harris County is Houston, home of the award-winning national champions, the Astros. And Harris County Jail is known to be the 3rd largest jail in the U.S. with an average daily population just under about 9,000 individuals. We estimate that there are over 1,500 individuals that are in the jail at any time that have a history of mental illness, that also have a history of being homeless. We also estimate that there are at least 2,000 detainees at any time that are on psychotropic medications. Cost of incarceration before trial is about 21 days. That's how long people are there before trial. The general population, $45 a day. The general population receiving psychotropic medication, $67 a day, and then the specialized mental health unit, you can see there that it's over $200 a day. And we estimate that there are at least 2,000 individuals who meet the eligibility criteria for our program, which really focuses on individuals that are frequently cycle through the jail. Next slide. These are our primary goals, which were alluded to, which are to reduce the frequency of arrests and incarcerations, reduce the number of jail the days that people spend in jail, and increase access to housing, behavioral health, and other social services. Also specifically focusing on the reduction of criminogenic risk. And I think that in the earlier slides by Dr. Cho, he really gave a good example of the importance of addressing criminogenic risk as we're moving forward with these types of efforts. Next slide. This is our eligibility criteria. As I mentioned before, our program is focusing on individuals who are frequently in and out of jail, and so we define frequency as someone that would have at least 3 or more bookings in a 2-year period. You can see we're looking, the diagnosis that we're looking at, which are primarily what we often call the big 3. We specifically included post-traumatic stress disorder because we wanted to make sure that we were able to cast the net wide for individuals who may have been connected with the military that would not be eligible for services through the VA system. We also tried to prioritize individuals between the ages of 18 to 35 to see if we could get a little bit ahead of the curve in terms of what we oftentimes see as chronicity within this population. Next slide. These are some of our exclusions. The 2 that I want to focus on specifically in reference to this presentation has to do with excluding individuals that had a history of arson or a history of manufacturing or delivery of methamphetamine. The connection of those specifically tie back into the federal guidelines for individuals that would be eligible for permanent supportive housing. And so we wanted to make sure that we were really very sensitive to that as well. Next slide. One of the things that we learned, and we know from data, is that there is a very strong correlation between homelessness and people who end up being incarcerated. So because of that, we wanted to make sure that we had an array of housing options for individuals. Any individual that is enrolled in our program will receive housing if they are open to that. We provide a maximum of 90 days of housing support for individuals who are literally homeless. We have these various housing options that include some level of support. Emergency housing is primarily housing that is being used for people who are being considered for permanent supportive housing, because during that time they're being able to receive the assistance from a housing navigator to obtain identification and the other documents that they need to move successfully into permanent supportive housing. We have an array of housing providers. We also provide residential treatment for co-occurring disorders, and we'll move people directly from the jail or people who are already in the community or in PSH that are in need of some treatment for their co-occurring disorders into treatment services as well. Next slide. These are our program components, and you can see on the screen the services are provided, so I'm not going to go into much detail within those. We do have a jail team. The majority of people that we enroll in our program right now are people who are coming from the jail, and so we have a team of individuals that are housed in the jail that are providing services there. We have our own unit within the jail that's provided to us by the Harris County Sheriff's Office, and we're able to provide those services to individuals on an intensive basis while they are in the jail. Sadly enough, we're only able to have that one unit specifically for males. We have 2 community-based teams that help with the transition of individuals that are coming out of the jail, being released from the jail, but also for those individuals that we identify that are eligible for our services who are out in the community. The critical time intervention team, which again is an evidence-based practice that is shown to have a lot of effectiveness in working with individuals who are homeless that have behavioral health issues, is the team that gets assigned to those individuals that are at highest risk based on the assessment that we did look at for their criminogenic risk factors. Also those individuals that have the the more intensive substance use histories, as well as intensive psychiatric needs. Next slide. We have a permanent supportive housing component within our program array, and we have two providers that are part of that component. One is Healthcare for the Homeless Houston, which is a long-term provider for health services, primary health services for individuals that are homeless, as well as some behavioral health services as well. And you can see the other array of services that they provide. Healthcare for the Homeless and our PSH model is one where we do have an integrated health, primary care, and behavioral health model, so that these individuals will have access not only to behavioral health specialists, but also to community health workers and nursing staff as well. Next slide. Search Homeless Services is our other partner in the provision of permanent supportive housing. And they're the ones that have the housing navigators that are there to work with individuals, getting them into PSH. With it being a permanent supportive housing model, there are staff that are assigned to the properties. We have two properties that we are involved with where people going into our PSH component are being housed, and they have on-site offices there. We focus a lot on the motivational interviewing, and which is another evidence-based practice to really look at where people are in terms of their statements or readiness for change, and integrating cognitive behavioral therapy throughout all of our program components, specifically focusing on criminogenic risk factors. Next slide. So this slide shows you a little bit about our overall outcomes for individuals that have been enrolled in our program. And again, these outcomes and what we were really targeting or looking at are very much in line with those goals of stepping up, where we were really looking at being able to come up with data that showed a level of cost effectiveness, looking at the impact of recidivism. And you can see that for those individuals that had been enrolled in our program for at least a year, that we were able to reduce the cost of the amount of money that was spent for them in jail as we looked at those individual booking costs. We were also able to reduce the number of individuals that ended up coming back to jail. And for those people that ended up coming back to jail, we had a reduction in their jail days, fewer jail days. Again, all in line with some of those general outcomes that were identified within Stepping Up. You can see that the majority of the population, and I think this data is very similar to what you're seeing in jail populations in general, higher numbers of African Americans, large numbers of our individuals were diagnosed with bipolar disorder, and a strong percentage with substance use as well. On average, we usually see about 88% of our population that has an issue of co-occurring disorder in terms of both substance use and as well as a mental health diagnosis. Next slide. I can't say enough about the relationship that we've been able to have with our housing colleagues, and particularly the people that are working with the Corporation for Supportive Housing, because it was through the Corporation of Supportive Housing that basically came to us and it said, can you help us share some information about what you've been seeing specifically in terms of the impact of housing on the population that we've been working with? Because the majority of people that we are seeing going into our program through the jails are people that are homeless. You can see from this information that we have individuals that are not only being categorized as being literally homeless, or those individuals that would not meet the federal definition of being chronically homeless. One of the reasons that we have so many people that don't meet the federal definition of being chronically homeless is because we have people that end up staying in jail for longer oftentimes longer than 90 days. And if you are in jail longer than 90 days, or in reference 60 days actually, the jail is considered your home. And so therefore that breaks up the way that you can count your issues in terms of being able to document chronic homelessness as far as your category is concerned. So within what we looked at in our study was looking at the average number of bookings for people before they were enrolled in our program, looking at bookings 1 year after treatment, also getting a handle on the types of charges that people had going into the jail, both misdemeanors and felonies, and then looking again at those types of offenses 1 year prior enrollment and during enrollment, as well as 1 year after they had been enrolled in our program. Next slide. So these are some of our overall results, which would be of a lot of interest, particularly on this call. What we found is that overall, not only in terms of individuals that met the federal definition of being chronically homeless, but also those individuals who would be considered literally homeless. And these people that are being considered literally homeless are not people that only had one episode of homelessness, but are people that also have more than one episode of homelessness during the year. Is that we were able to show a reduction in the number of bookings as well as jail days. In terms of our chronic homeless population, those with permanent supportive housing, the average number of bookings went from 2 to less than 1. So that was a very strong effect. We were also able to show a reduction in the number of bookings for individuals that were literally homeless as well. And that was met a level of significance also. Next slide. Next slide. Okay. In terms of looking at the results for housing costs, again, in the previous slide that I showed, you could see the array of housing services that we do offer. Emergency housing is something that we offer primarily at residential hotels, where individuals have, one of those long-term hotels where you have a little kitchenette and that kind of thing. And so those costs we were looking at in terms of about $42 a day for people that we were placing in emergency housing. Our temporary housing were primarily in other congregate housing arrangements where people were living in group settings, and that was at a cost of $30 a day for temporary housing. Chronically homeless clients without PSH, we ended up looking at about $46 a day for them in emergency housing. That's based on where it is that we were able to find that housing locations. The cost for the literally homeless population ended up averaging out about $44 a day as far as looking at their stay in emergency housing, and $35 a day. And this is versus the average jail cost. And we came up with that average jail cost of $149 by basically looking, combining the cost for individuals that were in the specialized units for individuals that had serious mental illness that needed to be in a specialized mental health unit, those individuals that were in the general population, and those people that were in the general population that required psychotropic meds. But what you can see is that overall, we're still looking at being able to provide housing support for individuals in the community at a much lower rate than keeping people within the jail. Next slide. So overall, our analysis found a reduction in criminal involvement for all of our homeless participants. All groups who received housing assistance experienced a continued decrease in the average number of jail bookings, as well as a decrease in jail days up to the period of post-treatment or when they had transitioned from the program. Also, for those individuals who did not receive housing assistance, bookings and jail days, as well as felonies and misdemeanors, generally, as well as felonies and some misdemeanors, generally increased again after treatment. So again, what we found that people that didn't get some level of housing assistance, they were at risk of continuing to have some levels of jail bookings, and that there was an increase more often from the misdemeanor status into some level of felony status for the types of crimes that they were committing. Next slide. And here is my contact information, and we'll be glad to share any other data with you that people might be interested in. So turning it back over to you, Natasha.
Great. Thank you so much, Dr. Hicks. I appreciate it. And what sort of a dichotomy of counties, Harris County, over 4 million people, Johnson County, around 140,000 people, but we know that housing is just a really significant issue for counties of all sizes and all geographies. And so I appreciate both of you being on the call today. And Kim, I know you work with counties from and cities all over the country on these issues, and so no one knows better than you the different ways that folks are finding housing solutions to work with folks with mental illnesses. So appreciate everyone being on the call. We have time for maybe one, maybe two questions if folks want to submit their questions through the questions box, and then I can ask them of the speakers. So go ahead and submit those now. While those are trickling in, I'm just going to make sure that folks know that our speakers, I think everybody except for Dr. Cho, are going to be on the network call, which is next week. So next Thursday at 2 o'clock Eastern, so same time next Thursday. And so on the network call, we're going to be able to address a lot more of these questions that have come in and have a little bit more of a discussion and dive a little deeper into some of the topics that have come up during this webinar. So we hope folks will join us for that. You're welcome to register at stepuptogether.org/toolkit. You'll see a link there to register for the network call. So please go ahead and register for that and join us next week. We appreciate it. I wanted to go ahead and ask just one question of folks, if everybody sort of wants to jump in. So one of the questions we got was actually about clubhouse models for housing, and whether clubhouse models for housing as an alternative to supportive housing, is that something that states and localities should be supporting, or something that you all have seen as sort of an option or an alternative as part of your efforts? I don't know if I'll let anybody who was on the call today see if they want to address that, if they're familiar with that.
This is Regina, and one of the providers that we use for our temporary housing operates under a clubhouse model, and that particular structure has worked very well with those people that we're working with that are not going to be eligible for permanent supportive housing. One of the other things that has happened is that we will initially pay for those people to be at that particular facility, but then as they become acclimated and really become an integral part of the program, then they're able to tie into that community, and then they start working and covering their own way, if you will, as far as that's concerned.
Nastasia, this is Richard. We just want to jump in here. I mean, my understanding of clubhouses are that they largely are a day programming facility and not necessarily residential. And if we're also talking about models of temporary transitional housing, I think there is a need for housing, as the speaker showed, to fill a gap between when someone might be discharged from jail and when they could enter permanent housing. But I think what some of the data that was presented here shows is if you don't provide people with permanent housing, and that is the main outcome and focus, what you end up having is that people continue to cycle between all of those emergency services, including emergency and transitional housing. And so I think it's really important to understand what success means in terms of achieving stable housing, which means that people are in a housing situation that is long-term and that doesn't have artificial time limits such that they don't continue to perpetually cycle between emergency rooms, hospitals, jails, and other temporary facilities that are more costly than housing.
Great. Thank you, Richard. Appreciate it. Thank you, everyone, for being on the call. I'm going to have to cut us off now because we've already gone over time, but just wanted to remind folks on the phone that the recording of this webinar, as well as the PowerPoint slides, will be available on the Stepping Up website, stepuptogether.org/toolkit. Give us, 24 hours or so to post those up online, and those will be available to everyone, because I know there's a lot of really good content that we heard from our speakers today. So I just want to thank our speakers again for their time, and thank you, all of you who participated in the webinar today, and those of you who asked questions as well. I look forward to having everyone register and attending the network call next week on Thursday at 2 o'clock Eastern, and I hope all of you have a wonderful day.